to assess an acutely unwell patient using the ABCDE approach. Before we get into the A to E approach itself, there are key things to remember. Number 1, make sure to assess each component separately. Number 2, whilst assessing each individual component, think about any potential investigations and interventions that may be beneficial for the patient. And finally, number 3, do not move on to the next step until you are happy that you are satisfied with the component you are on. For example, you wouldn't move on to assessing the circulation if there was still a significant breathing problem. So let's break down the steps. A is for airway. The simplest way to assess the patency of an airway is to talk to your patient. Ask them a question like, "How are you feeling?" This allows you to gather an ample history whilst also assessing the airway. If the patient is alert and talking to you, you can happily conclude that the airway is patent and move on. However, if you have an unresponsive or distressed patient, your assessment may include more steps. Firstly, look at the airway. Look for blood, a visible foreign body, vomitus, and secretions. Also listen for sounds that may indicate airway compromise, including snoring, stridor, and hoarseness. Suctioning under direct vision, adopting airway maneuvers such as the head tilt chin lift or jaw thrust, and use of airway adjuncts are just some of the ways that you can try to improve the patency of an airway. However, this will not be fully covered in this talk. Ultimately, if there are any airway concerns, seeking anaesthetic support is the most appropriate option. Now B, breathing. To begin with, there are certain observations that give you important information about a patient's breathing, and it is vital to ask for these. They include the respiratory rate and oxygen saturations. Next, look at the patient's breathing. Are there signs of respiratory distress or accessory muscle use? And are there signs of cyanosis? Palpate the chest wall and assess for expansion, and feel for the trachea to check that it is central. Listen to the lung sounds and check for equal air entry and any added sounds such as crackles or wheeze. There may also be absent or reduced breath sounds. Make sure to percuss the chest. Hyperresonance suggests a pneumothorax, whereas dullness to percussion may indicate a pleural effusion. Whilst assessing B, you may run into some problems. For example, the patient may be tachypneic or hypoxic. Think about what investigations you may want to request which will help aid your diagnosis, such as a chest X-ray, arterial blood gas, or peak flow. At the same time, you may be needing to intervene. For example, that hypoxic and tachypneic patient may need oxygen or nebulizers. When managing an acutely unwell patient, guidelines typically state to commence 15 litres of oxygen via non-rebreathe mask in the first instance, and this can then be down titrated according to target saturations later. Remember, if you intervene and try to correct a problem at any given step, make sure to reassess your patient and be satisfied that you have adequately corrected any issues before moving on to the next system. C is for circulation. Similarly to breathing, there are important observations to ask for, which will help you with your assessment, and this includes heart rate and blood pressure. Problems with the circulation often appear with these deranged readings, so it's important to check them together. Looking at your patient, there may be signs of pallor and sweating, which could indicate shock or blood loss. Assess the patient's fluid status and level of hydration. Palpate the patient's peripheral and central pulses to assess the rate, character, and volume. A distal radial pulse that cannot be palpated indicates significant hypotension. Another important marker is assessing the capillary refill time. Make sure to check this centrally by pressing over the sternum for at least 5 seconds before releasing your finger. And finally, listen to the heart sounds. Investigations that may support your diagnosis include an ECG, echocardiogram, and inserting a urinary catheter to measure urinary output. It is also really important to think about establishing IV access at this point. This will allow you to take bloods, a VBG if you haven't done an ABG in order to get a lactate reading, and blood cultures. Secondly, once IV access is established, you can administer important medications, including a 500 ml crystalloid fluid bolus for a shocked patient, or intravenous antibiotics. Again, remember, if you are going to intervene, make sure you reassess your patient and you are happy before moving on to the next step. D stands for disability. One of the main things that you will need to establish at this stage is the patient's conscious level. Different tools can be used, including AVPU and GCS. And this should be combined with a brief neurological examination to look for lateralizing signs, a pupil assessment, and looking for any signs of a head injury. D also stands for don't ever forget glucose. So make sure you check the patient's blood sugar. Now, personally, I like to think about drug chart under D2, particularly if there are any concerns that the patient may be taking sedatives or opioids that could be leading to a reduced conscious level. After measuring blood sugar, another important investigation to consider for D is obtaining a CT head, particularly if there are any concerns about an intracranial event. Interventions can vary depending on the underlying pathology, but may include administering intravenous glucose, reversing opiate toxicity, or maintaining neuroprotective measures in the event of intracranial injury and preventing raised intracranial pressure. And finally, E is for everything else. This is your opportunity to fully expose the patient and look for important clinical signs, including rashes, injuries, and potential sites of infection. Make sure to check the patient's temperature at this point. You may be less likely to need to request investigations at this stage, and it will depend on what you find. For example, a wound swab may be indicated for an oozing skin lesion. Likewise, interventions will vary depending on what you find, but you may need to correct extremes in temperature, such as administering warmed IV fluids and using a bear hugger to treat hypothermia. So now you've completed your ABCDE assessment. And you may be thinking, so what happens next? Perhaps you need to call for senior support or a specialty. When handing over a patient, make sure to use a tool, such as SBAR. SBAR focuses on handing over the situation, followed by the patient's background, your assessment, and your recommendations for the patient's onward care. So, to conclude, the A to E assessment is a really useful way to assess an acutely unwell patient, and it offers a systematic approach. Make sure to think about investigations and interventions at each step, and do not move on to the next system until you have stabilised the current one. Reassessment is crucial. If you get lost at any point during the A to E assessment, you can reassess. And if you intervene at any point, again, make sure to reassess the patient. If you like this video, make sure to follow MediKing.